Routine prenatal testing and diagnostics. As an introduction, routine prenatal care is the testing essential for midwives and obstetricians to monitor the health of the mom and the baby. They're going to do it through performing and interpreting those screening tools from the very beginning of prenatal care all the way to postpartum care. Prenatal care typically starts between 8 to 12 weeks, sometimes a little early if they have complications and need additional screenings if there's bleeding and miscarriage risk, all the way till 8 weeks postpartum. And you're going to be watching for bleeding risk and screenings, repeating a gestational diabetes screening if they have any issues, mental health screenings. There's a lot of tests that a midwife and care provider does throughout the pregnancy and birth that's really important to know what they are, when to utilizing them, and how to interpret those findings. Key areas of routine prenatal testing and diagnostics. Initial screening and blood test. Early prenatal screenings assess the maternal health. They identify risk and establish pregnancy baselines, detecting potential issues before symptoms appear. Typical things in a prenatal panel include blood type and Rh factor to determine if they're Rh negative or positive, O negative, O A positive. If they are Rh negative, there is recommendations with any blood interaction in the pregnancy after 12 weeks to give them RhoGAM preventatively at 28 weeks, and then to check the baby's blood type after delivery to see if the mom needs RhoGAM if the baby is Rh positive and the mother is Rh negative. CBC is a complete blood count and typically checking for anemia, infection with white blood cell, and other blood conditions. Infection screenings. All over the country, there's different panels they'll do for STIs, but the core ones are syphilis, HIV, gonorrhea, chlamydia, and the goal is to prevent transmission of infection from the mother to the baby. Hepatitis B and C is pretty standard across the country, detect infections early, and to make sure during the pregnancy and birth, the interaction with the baby and exposure risk. Urine tests, checking for infections, protein, sugar in the urine. It's pretty typical to do a urine culture the initial prenatal visit. If there's any bacteria, even if the mother isn't having signs and symptoms of an infection, you typically give antibiotics because of the risk of increased preterm labor. If the GBS positive in the urine, you don't do the screening again at 36, 37 weeks. They're just positive the rest of the time. And then the recommendations based on CDC is antibiotics during labor if the GBS is positive at any point in the pregnancy. Genetic screening and diagnostic testing is typically started at 10 weeks gestation, but you can have conversations of those tests. Some are diagnostic and some are screening, and it's really important for us as care practitioners to understand the difference and educate our families. Screening is a risk ratio. So the Natera, the Maternity 21, the quad tests, they tell a probability. Your patient is 1 in 200, 1 in 20, 1 in 20,000 chance. The test will say positive and negative, but each screening has a criteria threshold, typically 1 in 200, 1 in 300. If the risk ratio is higher than that, meaning they have a higher chance of that occurring based on other people in the population, then it'll come back as a positive. It doesn't mean that person has Down syndrome. It doesn't mean that their baby has a genetic issue. It just means the probability is higher. It's based on the blood being drawn, the mom's history, how old she is. There's a lot of factors that go into that risk probability. And then if it's 1 in 10,000, it's a low risk, it's going to come back negative. It doesn't mean the baby doesn't have it. And it's really important for families to understand that. Diagnostic testing is very invasive. That's a chorionic villus sampling. That's actually getting DNA from inside the mom and the uterus and from the baby directly. And very few people choose diagnostic genetic testing. Most people choose genetic screenings because they want to know the gender of the baby at 10 weeks versus waiting for the anatomy scan at 20 weeks. First trimester, we talked about there's ultrasounds, the nuchal translucency, 11 to 13 weeks, to also increase chance of chromosomal issues with like Down syndrome, and then the blood screenings. There's the NIPT that we've already talked about that's at 10 weeks is one of the chromosomal testings for screening for blood from the mother. And then the amniocentesis and the chorionic villus sampling is more higher risk pregnancies, and it's a diagnosis genetic screening versus a screening just for ratio. Ultrasound imaging is becoming a very common part of prenatal practice in the US. Some practices do it every single visit, some just do it at 20 weeks. I would say most places across the country, they'll do it for reconfirming the dating based on that last menstrual period between 6 to 10 weeks gestation, and then at 20 weeks. But there's a few practices across the country, especially if they're low risk community hospitals, they'll do it again at 32, 34 weeks, confirm baby's head down, the fluid level's good, the growth is good, so that they are a small community hospital. And if they need to transition their patients to higher acuity facilities, they have time to do that. First trimester ultrasounds to confirm the dating, viabilities, or one baby, two babies. If she's having some bleeding in the pregnancy, confirm there's not a subchorionic hematoma going on. The anatomy scan is between 18 to 22 weeks. I try to encourage patients to do between 22 to 24 weeks because that's their highest probability to be able to get the heart valves and the spine really well. If you're doing it 18, 19 weeks, most of them are going to get a second ultrasound a month later. And it's always a risk benefit of like the cost and the expenses of healthcare and absorbing things like if people can be patient and do it closer to 21, 22 weeks, we're going to have far less double ultrasounds just because the sonographer can't see the heart, lung, and the anatomy as well at that 18, 19 weeks. Growth ultrasounds, if you have people with growth restrictions, diabetes, hypertension, advanced maternal age, complications in the pregnancy, oligohydramnios, they tend to do growth ultrasounds. If you're doing prenatal visits and they're measuring big, they're measuring small with their fundal heights, ultrasounds can be a great point of care testing, especially midwives is part of our scope of practice as nurse midwives in particular to get ultrasound certification. There's not much positions statements out there for CPMs and direct entry midwives at this point with ultrasounds, but it's getting more and more that community-based and independent midwives are doing their own ultrasounds. We don't do anatomy scans, that's a diagnostic testing versus point of care, but we can do position, we can do fluid, we can do a biophysical profile, we can do growth, we can do dating. There's a lot of great trainings available to do ultrasounds. Screening for gestational diabetes. Typically, it's done at 26 to 28 weeks. Most places across the country will do the 1 hour glucose tolerance test. Some places will do the 2 hour glucose tolerance test. Some will just make everybody do the 3 hour glucose tolerance test. The 3 hour is kind of the standard hallmark, but most people, it's hard for them to do. So I would say most practices do the 1 hour glucose tolerance test, the GTT, and if the moms pass it, then awesome, great. If they don't pass it, that's a pre-screening that they officially have to do the diagnostic version, the 3 hour GTT. For if they've had a history of big babies, diabetes in the past, obesity, a lot of practices nowadays are also doing diabetes screening at the beginning of their first visits. If you get the diagnosis of elevated sugars before 20 weeks, they'd have type 2 diabetes versus pregnancy diabetes. And then you're usually doing, again, the glucose testing at the 6 week postpartum visit to confirm that as soon as the placenta delivered and she doesn't have the stress of the pregnancy, her blood sugars are going back to normal. There's a lot with alternatives. There's a lot of recommendations and mixed research of A1Cs, jelly beans, using the fresh test for a drink, doing home monitoring for a week. It's especially with community-based midwives, there's a lot of alternative testing out there, but the current medical gold standard is to do a 1 hour glucose tolerance test between 26 to 28 weeks, and then do the final diagnosis test of the 3 hour if they don't pass the 1 hour. And then if people have risk factors, to do the diabetes screening at the beginning of pregnancy. Screening for hypertension and preeclampsia, especially post-COVID, there is a lot more blood pressure issues, preeclampsia, coagulative issues, complexities that are occurring. People are just getting sicker with stress and mental health and obesity. It's just people are getting more and more high risk. And so there's a lot with screening at the beginning of the pregnancy. What's their blood pressure? Getting a baseline labs for preeclampsia, checking a CBC, a CMP, a uric acid, a protein creatinine ratio, and getting a sense of their baseline liver kidney function. If they have risk factors, first baby, bigger, had a history of preeclampsia, older, BMI that's large,
new father or baby in the picture, there's risk factors for preeclampsia and hypertension. If they have chronic hypertension, you want to get a baseline at the beginning of pregnancy because you can get superimposed preeclampsia on top of chronic hypertension. If the blood pressure is elevated before 20 weeks, you're suspecting they have chronic hypertension. If you get two blood pressures elevated, 140s over 80s or higher, 4 hours apart after 20 weeks, that's pregnancy-induced gestational hypertension. And then once you start getting elevated protein in the urine, you start getting labs that are off, you start getting the protein creatinine ratio elevated, you start getting a headache, right upper quadrant pain, increased swelling, especially towards the end of the pregnancy, you start tipping into that severe versus mild preeclampsia based on very specific parameters that are written. So it's really important to educate patients because they can get sick pretty quickly with blood pressure and preeclampsia issues. So early interventions really can help prevent complications by keeping a close eye on patients with labs, blood pressures, testing, and assessment of symptoms. Heart rate monitoring. During the pregnancy, we do a Doppler. Some practices will do fetoscopes, and during labor, many women in the hospital setting are on continuous monitoring, even though it may be a wireless system to not restrict them so much. Out of hospital midwives are using Dopplers and doing intermittent monitoring, and then higher risk patients in the hospital setting are typically continuous monitoring to keep an eye on the baby. Heart rate 110 to 160 is the normal range. If it's above 160, it's tachycardia, and if it's lower than 110, it's bradycardia. And there's certain things we're watching for: that bounce to bounce change, the moderate variability, accelerations. Certain decelerations are acceptable, like if you get an early deceleration, a dip in a heart rate with a contraction, it's head compression. If you're getting a dip with a heart rate after a contraction, that's a late deceleration, and it makes you worry more about oxygen concerns. If you get a quick dip in the heart rate, it's called a variable, and that's typically cord compression, especially if it's repetitive. You worry about the fluid level, you worry about where the cord's at, and can the baby handle that stress over time. There may be additional times where there's non-stress tests throughout the pregnancy, 32 weeks onward with diabetes and twins and advanced maternal age and obesity and hypertension and growth restriction. They tend to do extra testing and keeping a closer eye on the baby. And a non-stress test is 20 to 40 minutes of continuous fetal monitoring and looking for certain well-oxygenated signs. And if they don't see those, then they order a biophysical profile. There are some additional testing based on specific complications that can occur throughout the pregnancy. The GBS screening, that's between 35 to 37 weeks. Most practices are doing it between 36 to 37 weeks now because the results are good for 5 weeks being negative. So then you don't want to get into that weird limbo land between 41 and 42 weeks where you got to repeat it. And then is it going to be positive? Is it going to be negative? And then the worry about antibiotics during labor, particularly in the hospital setting. Thyroid function tests, if they have a history of hypothyroidism, hyperthyroidism, TSH, T4, T3 are typical thyroid panels that are done, especially people on meds and close monitoring every 4 to 6 weeks, repeating that if they have a past thyroid disease diagnosis. It's really, really important for fetal development to have the thyroid function within a tight parameter of normal. And so keeping a close eye on that. And I see a lot of practices just don't, which surprises me. Bladder infections, we usually don't care if she's not having symptoms outside of pregnancy if there's bacteria present. But in pregnancy, that's why we do a urine culture at the beginning, because it can lead to an increased risk of preterm labor. Collaboration and referrals. Midwives are independent care providers. We are amazing at taking care of low-risk, healthy families. But people are getting sicker and sicker, and there's just more and more out there to worry about. And so it's so important that midwives collaborate and refer to their specialists in their community, their obstetricians, their neonatologists, the perinatologists, the pediatricians, the cardiologists, the maternal fetal medicine. We work as a team, and that's where we get the great outcomes. I see so much disparity risk when midwives are super independent and they don't have a collaboration until they desperately need it, and then their answer is sending their patient to the ER, the urgent care, labor and delivery. And then extra hoops and delays in care and frustration occur with both sides, and the patient gets stuck in between that not set up collaboration model.
As an overall conclusion, we talk a lot about routine prenatal testing is really a core to midwifery care. There's different aspects all over the country of what's high risk, what's low risk, what are community risk factors, but there are core things throughout pregnancy, labor, and birth that are pretty national and international standards to be checking for. Checking blood pressure, checking weight, checking the measurements of the baby, checking the heartbeat, checking and asking questions about bleeding and discharge and cramping and contractions and pain and concerns that the patient's having. And then based on their assessments, their history, the midwives are going to order and do testing that's routine at that point in the gestational period, or they're going to add additional tests based on how the patients answer their questions.